Thank you. Welcome, everybody. I'm from the States, and as you probably know, we welcome controversy. So I'm open to a lot of questions, just none about politics, please. Um, so I was assigned the topic of FAI syndrome. So it's a very broad topic. I'm going to cover a lot of things probably here, and but obviously a limited amount of time. So do welcome pictures and tweets and that kind of stuff. But and some of the slides might go a little bit quick. But so first of all, I want to thank the committee for inviting me. It's an honor to be here. It's an honor to be with these great speakers, and I want to thank Mario and Julia and everybody that made this very easy to get here and to be able to do this, and hopefully I've translated those terms correctly. So what is FAI syndrome? And so it's essentially is either the femoral head is too large or the cup is essentially too deep. It's a mechanical abutment of the femoral head against the acetabulum. And part of the reason it's such an honor to be here is this concept has been around since the 1935s with Smith-Peterson, but where it really took hold and where it really became very popular was with this article from Gans, and so it's kind of an honor to be in Switzerland speaking about where this really became popular, and I'm sure that you all know of this article, but this is so recently an article they looked at the 50 most popular FAI articles. This is by far number one. It's by far the most cited and most referenced, and in this article, they talk about the concept of the mechanical abutment of the head against the acetabulum with a potential cause to cause labral tears and osteoarthritis. Since that 2003 article, other groups have tried to quantify and kind of put some structure to that diagnosis. And so there was a group that met in 2012, American Academy of Orthopedic Surgeons, and from that came 3 articles, and they were trying to look at diagnostic imaging, clinical, and terminology. And so they tried to figure out, can we put parameters to this diagnosis? Can we put, do you need a certain alpha angle? Do you need certain things? And then since then, there's been a few articles written, and part of my PhD is on FAI syndrome. So, but as I was looking through a bunch of these various articles, I found that these people are quite different, and these people are not all the same. And so, so I tagged with Christian, who does not mind any controversy, and we decided that maybe we should call this FAI syndrome. So we proposed that as a name, and luckily it kind of has stuck and now has been adopted by the Warwick Agreement that was published in 2016. So again, just that what it is the head is too large or the cup is too deep, and it creates some potential pathology. But first, you kind of have to understand is how prevalent is it? There really are, to my knowledge, I think this is the only one, but there are not really population studies that look at how prevalent is FAI in different populations. I think part of the problem is figuring out what's the parameters. How large does the head have to be? How deep does the cup have to be a problem? But if you look overall, at least in the Netherlands, it's not very common. Less than 1%. And of the 84 people that actually had hip pain, only 17% of them actually had FAI syndrome, according to their definition. If you look, and this was in the States article, this was a descriptive epidemiology study from the States. And if you look at people that actually have FAI syndrome, what characteristics do they have? The suggestion is that it's a little bit more common in females. Several other articles don't completely agree with that. But it seems to be race is pretty much, was 88% for white. The most common things so what a cam is the measurement of the size of the femoral head, and I'm not going to go through all the details of it, but essentially a cam is measure the size of the femoral head. The larger the femoral head, the larger the cam and subsequent alpha angle. What's very infrequent in this large descriptive study and has been supported in following studies, and we published a scoping review that found very similar numbers to this, is it seems to be that it's more on the femoral side or femoral and acetabular side. It's very rare for it to be on the acetabular side only, which is what is termed pincer. So what about diagnosis? And if we look at the history, and this is kind of part of my reasoning for wanting to call this syndrome, and I'm not sure that's still the right term, but these people have pain for a long time. And this is just one study that showed us, for up to 4 years. These people also have been to multiple physicians and surgeons and physiotherapists and have had injections and different types of imaging. And so they have this condition for a long time. And a particular patient like this is kind of what started my whole research into FAI syndrome. If you look at the Warwick Agreement, talks about emotion-related disorder that has clinical signs, symptoms, and radiographic findings. And in there, they suggest that you need to have all three of those for somebody to have truly FAI syndrome. It's not just an imaging diagnosis. It's not just a positive hip impingement test. So what I'm going to go through is I'm going to go through those three and kind of tell you what has been suggested to look at, what has actually been looked at, and what is the value for each of those tests. So in 2017, as part of my PhD, what we did is we did a Delphi study to ask experts in the field what subjective things need to be asked for somebody to be a descriptor for FAI syndrome. The things that we came up with were very commonly deep-seated hip groin pain, pain with mechanical movements, deep aching pain, stiffness in the hip. Those were the kind of the common themes. What is actually utilized? So in the same year, in 2017, we also published a scoping review looking at all the surgical outcome studies. So all the studies that described surgery, and what did they actually utilize as indications for somebody to go to surgery? So do they follow what has been suggested? And what we found out is very similar. So symptomatic hip pain, stiffness, limited moderate to severe groin pain. Interestingly enough, is this was suggested for mechanical hip symptoms. That was not suggested by the experts in the Delphi study. Some experts believe that mechanical symptoms, clicking, catching, those kinds of things are more indicative of labral tears, but those FAI and labral tears are fairly common together. So what is that? What is the diagnostic value? Unfortunately, we don't know. Okay, there have been some studies that have been published out there. Keeney and other authors have published. The lack of mechanical symptoms seems to help rule out labral tears. A lack of groin pain seems to help rule out intra-articular pathology. But there have not been a systematic review or anybody that's systematically looked at that. What about physical examination? So what has been suggested is limited hip internal rotation, limited hip flexion with internal rotation, range of motion loss. What's been utilized? If you look at what's been utilized and what we found out in the 108 studies that we looked at, of all these people, the surgical studies, the biggest thing was limited hip flexion and internal rotation. So kind of getting into kind of a hip impingement type of test. Limited internal rotation was suggested in 20%. Non-specific was the biggest category, and I think that's part of our problem. What is the value? Again, there are not diagnostic accuracy studies published on these variables, but there are some studies that have looked at some of this. And if you look at range of motion limitations, there's been a couple different systematic reviews. There have been a couple of subsequent studies that have looked at this kind of stuff, and essentially there does not seem to be an exact agreement on what oftentimes is proposed and suggested and been advocated for is a limited hip internal rotation, especially at 90 degrees of hip flexion. That's not always completely supported in the literature. And the other thing to think about is there's studies that suggest with a large cam you have limited range of motion. That definitely makes mechanical sense, makes biological plausibility sense. There are some studies that do support that, But there's also some studies that question that. And there's some studies that suggest that maybe that this CAM and limited internal rotation are actually independent of each other. Some other articles suggest that it may not be the CAM, it may not be the femoral head. It actually may be torsion, so where the femur torsions on itself. And the study by Krautler here at the bottom actually suggests, and what they found out is they compared to people that had retrotorsion, so the humerus torsioned posteriorly, which would inherently limit internal rotation. People that had torsion or retrotorsion actually had more limitations in internal rotation than people that had CAM. And he even had two groups. He had one group that had torsion with a CAM and torsion without a CAM. The people that had torsion and no CAM had larger losses of range of motion for internal rotation. So obviously there's something to try to figure out here. And maybe it actually happens to be a sport-specific adaptation. You know, if you look back to the shoulder and GERD or limited internal rotation with shoulder throwing, that's a result of repetitively throwing as a result. The humerus actually torsions on itself. Maybe that is something that goes on in the hips. Because if you look at American hockey players, one study found that they actually had limited external rotation. And if you look at American football players, a study by Kaplan in Utah suggests that their football players have a limited internal rotation. The majority of them have that, and maybe not all of them have pathology. So it's yet to be determined on range of motion. What about special tests? What is suggested? The most commonly suggested test is Fader's test. Flexion to 90 degrees, adduction with overpressure, and then internal rotation with overpressure, trying to create that mechanical abutment of the femoral head against the acetabulum. What's been utilized is it's predominantly the most utilized test. Some people call it anterior impingement test. Some people call it Fader's test. What is less utilized are the other tests like Faber's test or McCarthy's test or labral stress test. What's the diagnostic value? So this is part of what I looked at in my PhD. And essentially, the take home from this is, there's a large proportion of people that have this test positive in surgical studies. And so from our systematic review, we found a pre-test probability of 90%. What that means is before you even do the test, the probability that that person has FAI is 90% out of 100%. If I did a positive test, I had a very small shift in probability, okay? And essentially, my post-test jump in percentage stayed the same. I went from 90%. With the positive test, I stayed at 90%. Essentially, the test did not help me at all. I could have done it or not done it, and it would not have made a difference. What about a negative test? A negative test actually was a little bit more helpful. You had a moderate shift in post-test probability. And if you look at the percentages, now you go from 90% pre-test probability, you do the test is negative, now your probability drops down, now it's only 34%. So with the negative test, you want your probability to drop towards zero, so this is a good result. You want your shift to drop significantly down. And so you might look at that and say, well, that's awesome. I do that test, it's negative, and they don't have the problem. The problem with this, with such a high pretest probability, the rates for false positives was enormous on here. And I won't get into how you calculate specificity and that kind of stuff, but essentially there were a lot of people that were falsely positive on this test. And the confidence interval of this 34% ranged from anywhere from 5% to 95%. So it could have actually gotten worse. So you could have done the test with a 90% pretest probability, had a negative result, and your result went up 5%, which you don't want it to do. What about physical performance measures? So the one that's most commonly suggested is Ianni's maximal squat test. So the patient stands, they squat down as far as they can, and to see if they have pain. What's actually been utilized as a surgical indication for somebody to go to surgery? None of them have been reported. What's the diagnostic value? If you look at Ianni's study, he had the patient squat, see if they had pain. Now you look at pretest probability is only 41%. So you have room to grow or drop, right? Versus if you're at 90%, you're topping out. You have a ceiling effect. Now if I have a positive test, of a very small shift, unfortunately. Okay, so it's still, if you're familiar with likelihood ratios, you go from very small to moderate to large. So essentially you want them to get larger. And if you look at how much it changed, is if I did the test, they had pain with the squat, that increased my probability of they having the condition from 41% to 47. It only improved 6%. What about a negative test? Fader's test was awesome for negative, right? So the problem here is now I still have a very small shift, right? And I do have a fairly significant, I mean, I have a little bit more of a drop with 11%, but essentially, even this test with a low probability and functional is not a good test to discriminately say somebody has the condition or does not have the condition. And quite honestly, this is part of what I do as for my examination. And I do see this a lot clinically. This was a very disappointing result for me, and I spoke to the author about it, and he was quite disappointed as well. So I think maybe there's some things that you can play with it and do as well, but the results are what they are. What about diagnostic imaging? So this is the majority of most of the diagnoses. When we did our Delphi study, there was tons of suggestions, right? So we tried to narrow it down as much as possible. The main thing that people looked at was alpha angle. And so what, again, an alpha angle is, if this is your femoral head, this is your acetabulum, all they do is find the center point, and essentially is you measure where the bump starts, right? Is essentially where the circle is broken. A big suggestion was intra-articular injection, which has not been utilized very much. If you look at what's actually been utilized, is an alpha angle. The biggest number that people used was greater than 50 degrees. So it's fairly low hanging. And I think in the current literature, most of us would suggest that that's probably too low. Maybe 60 degrees, from some of Rinchi Agricola's work and stuff. But the point is, it was fairly low before these people went to surgery. I mean, it was a fairly small alpha angle. The value for a positive test in blue is you have anywhere from a small to a large shift. MRI and MRA seem to have the larger shifts, and the negative result is moderate to large. So again, your clinical exam and your diagnostic exam with imaging is probably a little bit stronger to screen or rule out the diagnosis of FAI syndrome than it is to rule it in or diagnose it. All right, so a little bit about outcomes. So if you look at surgical outcomes, this is growing exponentially. Okay, so we did a scoping review and we published all the articles that were looking at surgical outcomes, and the rate of growth over a 7-year period up to 2014 was 2,500%, 25 times or 25-fold increase, and so it was enormous. And other studies have suggested this large growth, 600% of that growth, is coming from new surgeons. So this is definitely the new kid on the block. Everybody wants to do it, and it's very popular. And what's interesting is there's been a subsequent study that was published after ours that said we're not done growing. This is going to happen more and more. So if you're a physio or a physician, if you're a physio and you haven't seen this condition, you probably will, because this is being done more and more. And the other thing that's interesting is, who's doing it? Okay, obviously it's surgeons, but it's all over the world. The majority of it is in America, in the States. I mean, that was the large percentage, but there's a lot of countries that are adopting this surgery and doing this surgical treatment. But the concern here is, are they getting better, right? And so, this was a systematic review that we published, and it looked at, if these people have surgery, do they actually go back to their sport? And do they go back to their sport at the same level that they came into it with? And essentially, if there's been a couple of different systematic reviews published on return to sport, all three of them agree that the return to sport, going back to the sport, is about 9 out of 10 people. What we looked at is, do they actually get back to the same level, and do they perform at the same level? Unfortunately, performance was not reported in hardly any of our studies. What we did find is only 3 out of 4 people actually go back and get back to the same level of sport. How they perform, we don't know. until the study from Copenhagen. And these results were even less promising than what we found in our systematic review. And so what they found in this study is they clearly and distinctly defined return to sport. And that is a problem, because in different return to sport studies, it doesn't really say how they get returned to sport. Sometimes it says they're on the roster, sometimes it says they played an inning or whatever. So the definition of return to sport was very non-distinct. And in this group, they made it more distinct. And where we found 74% across all the studies, they found 57%. But then only 17% of them actually stated that they actually had optimal performance when they returned to their sport. So it's pretty disappointing. And if you look at the surgical studies, there has been this huge growth. Okay, there's been this 2,500% growth. The majority of that growth is still in level 3B and 4 studies. So the studies are not high level to that degree. In full fairness, looking at non-surgical studies, we're even worse. Right? We don't have as many. We don't have as high quality. There was a recent level 2 study just published in AJSM, and I know Joe Kemp is going to talk about this more, so I will leave this. I don't want to just complain that surgery's not doing its job, physio's not doing its job either. But if you look at what's out there currently, there are 2 randomized controlled trials where they've looked at physio versus surgery, kind of mixed outcomes, a little bit on those depending on the surgery and such. But the point is that we are getting better with our studies. And if you look on clinicaltrials.gov, there's now 39 studies that are registered for FAI syndrome. So the good thing is we're starting to look at this more, and hopefully, in a couple of years we'll have better tag on what this is. But I might question: Are we actually measuring the outcomes that matter, right? So if you look at the ICF model, is pretty much our outcomes are focused right here. We really don't even look at contextual factors, right? So, and if you look at a couple different studies, this is where I think qualitative research has a good play here. Is this study found it's actually part of the patient's makeup. Do they have good coping mechanisms? Do they have grit? Do they have resilience? Those people that had those kinds of things did better with their outcomes. And so, is it the treatment? Is it the patient that you're doing it on? What are the important things? And this was a study by Mannion, and he looked at patients' expectations. What they did is they measured patients' expectations of their outcome for their surgery. So they asked them, is your pain going to be relieved with surgery? Are you going to be able to return to sport? What do you expect? And essentially Mannion said their expectations were out of whack. And what they found is the people that had the higher their expectations were, the worse their expectations were met. So they measured their expectations before, then they measured where they fulfilled afterwards. The higher somebody's expectations before surgery, the more disappointed they were after surgery. And kind of something newer here is looking at maybe mental health. I think there are a couple of studies that are suggesting that mental health conditions can be a confounding variable with these outcomes. And I won't go through all these studies here, but this study by Ron, what they found is they measured comorbidities, including mental health, on people that, before they went to surgery, and they measured the same comorbidities after. So surgery did not cause these comorbidities. These were present before the surgery. But what they found out is the comorbidities significantly increased after the surgery. So that's something to consider. Again, is it the patient or is it the treatment? So in summary, is our outcomes overall are not very consistent. They're not consistent for surgical, the huge rates increases. We have work to do in non-surgical as well. But in my opinion, these are not all the same patients. These patients are very heterogeneous. They don't have the same presentations. And I think maybe subgrouping some of these, maybe FAI syndrome subgrouping, which is very popular in things like low back pain. I think this is probably something that needs to be looked at. But is it a diagnosis problem? Essentially what I found from my work is the clinical exam is better at screening or excluding the diagnosis than it is at diagnosing. But even then, the clinical exam is not very good. Diagnostic exam is the same. It's a little bit better at screening, but still not great. Is it one of those things, do we need to start over? Hey, I mean, do we need to go back and actually do good quality diagnostic accuracy studies? Because in fairness to these studies that I looked at, some of them were surgical studies, and we extrapolated and pulled out the evidence, which is probably not fair to those studies. The problem, though, with starting over and redoing it is maybe the train has already left the tracks, right? Maybe we've already, because if you look at the literature, we're already doing cost-effective studies on FAI syndrome and surgical outcomes. We have, in my opinion, we haven't even figured out if we have these people diagnosed correctly. And then are we assessing the necessary outcomes? So take this with a grain of salt. I just was granted a PhD on diagnosis. My question is, does the diagnosis truly matter? I mean, does it matter if they have FAI or labral tear or ligamentum teres? Does that actually matter? Or do we look at things like prognosis? Do we look at things that, does somebody respond to a treatment? Maybe those things are more important. And really, the question that brought me into doing my PhD is I had this patient. And this patient that was not getting well, they had diagnosed FAI and labral tear. And where I was at the time, the closest surgeon was 9 hours away. And I had to try to decide, do I send this person for a surgical consult? And so I looked through all the literature and kind of came up with all the diagnosis, and that's where I became frustrated with this whole thing and started looking at it. And essentially is, as I've gone through this, and I think the question right now is, we just need to figure out, do they need to go to surgery or do they need rehab, right? And unfortunately, I'm not sure this is much more black and white than when I started. I think it's a little bit better. I think definitely if people don't have mechanical symptoms, don't have deep-seated groin pain, don't have pain with squat, and don't have Fader's test, I mean, those are probably good physio candidates. Thank you.